And it is hard to state. It's hard to for me to state just how influential Dr. Chow is in Southern California, particularly in Orange County. We're involved with some things in the Department of Social Work with Clayton and some very important organizational movements right now to try to make particularly behavioral health more responsive to clients and better in Orange County. But he's also got a very strong sense about integrated health, so behavioral health and medical. Okay? Dr. Clayton Chow, thanks so much for being here.
I don't know about work.
Oh, yeah.
It's all work. And so, thank you for inviting me to be here and have a conversation with you. Literally, that's exactly what happened. I just got into Hong Kong on my way to a 2 weeks medical mission in central Vietnam, and I got a text from Dave said, "Hey, do you want to do this?" And I said, "Sure, why not?" I love to talk to youngsters, right? So, and then I said, "Well, what do you want me to talk about?" And then he texted me a bunch of stuff and said, "And do that in an hour." And I said, "Sure, okay, let's do that." So, in the same vein of cultural competency, you see my name. You want to make a wild guess of what ethnic I am?
Is it Chinese or Vietnamese?
Vietnamese. Okay, what else? Sorry? Chinese. Okay. Any other guess? Ooh, very good. So my grandparents on my dad's side are Thai. They were actually exiled from Thailand to Singapore. That's where my father was born. My mom's side, my grandfather is Chinese, Han Chinese, and my grandmother is Manchurian, and my mom was born in Hong Kong. Both my grandfathers went to Vietnam to do business in the early 1900s. And significantly for my dad's side, we have a 4-syllable Thai last name, as you know. Thai last name is usually 3 to 4 syllables. But in order for him to do business in Vietnam, he has to naturalize to become a Vietnamese citizen. That was the law at that time. Put up by the French government because Vietnam in the early 1900s was part of a French colony. So they chop up the syllable because all Vietnamese last name is only 1 syllable. So we end up with Chow. And so everybody always think that that's a Chinese last name, but it's actually not. It's actually Chow Don Suan, a 4-syllable Thai last name. So I was born and raised in Vietnam. None of you, or few, except for a few of you, many of you probably have only heard it or read it in history book, if they have it in history book. We fled Vietnam in the late 70s. The term boat people, that's some of you teacher and advisor are familiar with, and you might have studied it in work history. So my family was part of people that came to Southern California. Well, no, actually, we didn't. We got to Lincoln, Nebraska in the middle of winter in 1981. And 6 months of that, we moved here to Southern California. Both my parents have friends and relatives living in this area. So that's my background. I was the first one in my family that went to college, and certainly was the first one in my family. When we say family, we meant extended family, not just the nucleus family. So I was the first one that went to college, and I was also the first one that went to medical school. But currently we have 2 physicians in on my dad's side. Actually, on my mom's side, there's no physician, so there are two of us on my dad's side. But we have other professionals as well. My little cousin in Texas just graduated with speech therapy degree. And we talked about it. For her, it was a decision between social work and speech therapy, and she decided to do speech therapy. I have social worker in my family. I have nurses, pharmacists, dentists, etc. So for some reason, we are drawn into the medical field, especially my family, my own nucleus family. All four of my siblings, with the exception of one, all four of them went into medical field. The one that is not professionally a medical person, but she did dabble into being a community health worker for a while. So in essence, all five of us. So there's a clip on my own story that would talk about why I went into medicine, particularly psychiatry, and I'm going to show it as a closing for our piece, because I want you to be concentrated on our conversation. And so Dave asked me to talk about mental health, integration of mental health, and what's happening here. How many social workers? Social workers see. There we go. Public health. And the rest of you are speech. Okay, communication. Okay. I think it will directly affect all of you, even those of you who go into speech, because you know for children with autism, speech therapy is an important part of the developmental recovery for children with autism. Okay. In fact, you should graduate with a lot of people wanting to hire you because there's a shortage of speech therapists that's related to autism treatment. And the reason being, only the last 3 to 4 years that autism treatment, ABA specifically applied behavior analysis, became a required benefit structure for any insurance plan, including Medi-Cal or Medicaid. So as you can imagine, there's a real shortage because people now realize that there's the benefit to help children with autistic spectrum disorder to get better. And so part of the requirement, at least in California, the full assessment involved in the assessment of a speech therapist. So all the insurance plans really pay attention to this, and I know there's a huge shortage. There's a very limited number of speech therapists as part of the network for any insurance plan. I know when I worked for the insurance, we struggle with finding good speech therapists to be part of the provider. And of course, public health, all the health plan that I worked for or have experience with, and even health system, my own health system, we hire people with master in public health to be part of the administrations of health system. So I don't think we have to worry about job shortage. My health system, we hire people ranging from manager up to director, up to vice president with a master's degree in public health. Now, if you have a doctorate degree, that would fast track you even greater, but with a master's degree in public health, you don't have to worry. If you're interested in management, you can get a job very easily. And then comes to my social worker. So I've always teased folks that even though I have the different letter behind my name, but my heart is a social worker. Dave knows that. There is a shortage of social workers. We know that for sure. In fact, if tomorrow all Americans with mental health condition raise their hand and said, I want treatment, we'll be in trouble because the mental health field, the mental health professionals, there's a definite shortage. we are predicting that by 2025, we will be in a crisis just because there is not enough psychiatrists, not enough psychologists, not enough social workers. Marriage and family therapists, we think we are okay, but social worker, the other professions in mental health field will be a huge shortage. We know that because not all social workers after graduation will go into mental health. Like some of you will go to school, some of you will go into the social work side of things, not really geared towards providing the therapy as a licensed clinical social worker. So there's a huge shortage. That brings to the point, well, how are we going to tackle this issue if we don't have enough mental health professionals? If we are publicly educating the community about mental health, about the importance of mental health, as you now know, David Satcher, the first Surgeon General, U.S. Surgeon General, who really pay attention to mental health, and he put this in quotation: "There is no health without mental health." So he was the one that really prompted the nation to really look at the issue of mental health, mental wellness, or emotional wellness. And then he's also the one who really pushed us to look at parity as it's related to mental health care. Have you all gotten a lecture on parity of mental health? No. Okay. Briefly, it means that if a health insurance spent $1 for physical health care, they have to demonstrate that they would be willing to spend an equal amount of money on mental health, right? So dollar for dollar. And this last 2 years, all of the insurance companies in the nation, including insurance companies that carry benefits for people with Medicaid, have to demonstrate that in their planning for services that they plan equally for mental health as they would for physical health. And I was part of that because before joining Public St. Joseph, I worked for LA Health Plan, which is the nation's largest nonprofit health plan. And we had to demonstrate to the federal government that in our planning for services for the people who carry LA Care as an insurance, that we actually calculated out that we would spend dollar for dollar on mental health as we would for physical health. And it's a complicated formula that we hired mathematicians to help us plug in all the numbers and calculate it out. And it was demonstration in that way on your financial side, but also you have to demonstrate your benefit that you're offering to people and the network of care that you have in your network for people with insurance that really have a well bona fide, I'm going to use the word bona fide, mental health network of care. And I will tell you that while people said they do, but the reality is they don't. Nowadays, you can still graduate and certify as a licensed clinical social worker, set up shops in certain area of Orange County and only take cash paying patient, and you will still have a very good business going. By that I mean, if you have insurance, even best insurance, finding a therapist, should you need services tomorrow, is a difficult thing to do. Most people who take insurance usually say, yeah, depends on which insurance. I can give you an appointment 3 weeks from now, or 4 weeks from now, or 5 weeks from now. Okay, some of you nodding your head. Hopefully it's not your experience, but sadly I would inform you that that's actually the truth. And if you're looking for a professional who is capable or actually trained in providing services, care for children, you're in big trouble. In Orange County, if you have insurance, the way to get in to see a child psychiatrist ranging from 4 to 6 months, 4 to 6 months. To get in and see a therapist who is well trained in providing care for children is about 6 weeks wait, including professionals who are licensed social workers. Okay. That's the issue. So if you have a child that is suicidal and need to be in care, the wait is that long. Is that acceptable? Not, right? But that's what we face.
So when you say treatment, are you referring to both medication
And
treatment
therapy. Yeah, so for the medication piece, it's worse. It's 4 to 6 months. But imagine if you got a broken leg today, you can go to an emergency room and get taken care of, right? You can get a cast within an hour. But if you're suicidal, you can't get anyone to see you right away. What does that say? So, noticing that we have that shortage, a group of us, a small group of us, started a decade ago, advocate for mental health services in the primary care setting. But it's an uphill battle because when we say a primary care provider, a primary care doctor, we mean people who get trained in pediatrics, people who get trained in internal medicine, people who got trained in general family practice, people who got trained in gynecology. Right? Well, all those 4 training programs are very different. And even within one disciplinary, it depends on where they went for training. Their background in getting trained in mental health varies. So a lot of primary care physicians are afraid to treat people with mental health. Unfortunately, in Orange County, majority of pediatricians hesitant, do not want to prescribe antidepressant to kids who are depressed. But I just told you, the wait to see a child psychiatrist is 4 to 6 months. So what to do with those kids who are suicidal? So I don't know if you know this, the rate of suicide in this country has been risen every year for the last decade. Have you got a class in that yet? Okay.
There's a little bit of research on it.
Okay, great. Orange County light up on the map. The number of kids who, when I say kid, they're probably more of your colleagues, people who are 24 and younger. I think majority of you in here are 24 and younger. So let me tell you this story. In Orange County, the number of folks who are 24 and younger die by suicide has been risen every year. In fact, we're in a critical condition now because in 2018 there were 14 death by suicide the age of 18 and younger. 18 and younger, so we're talking about high school. We are now in Q2 of 2019, right? By the end of Q1, meaning March 31st of 2019, we already have 17 deaths under the age of 18. 17. Right? Most of those cases are in South County. Okay? Those are the cases that we know of. Okay, so if a kid tried to overdose and did not die at home, but was admitted to the hospital and developed organ failure, right, because of drug use or what have you, and eventually die in the hospital from the organ failure, that is not reported as a suicide case. Do you follow me? Okay. If a youngster get intoxicated and intentionally get into accident, that does not get reported as suicide. Okay? Give you that fact. The number one cause of death for youth under the age of 24 is accident. The second cause of death is suicide. Do you think that youth really have a lot of accidents? You do? Okay. And would you believe that you who have the substance use disorder would be more likely to accidentally die? And some of those accidental deaths could be intentional. So now you see how the number doesn't make sense. Okay. Why I'm telling you this is because of we are in an era of lots of stress, right? Remember when you were in high school, that was very stressful. Well, high school is even stressful, much more stressful nowadays, right? And so stress, all this issue related to bullying and what have you, is causing our students, our youngsters to be under a lot of emotional turmoil. But yet we don't have a system of care that would be readily to help them. And that's why we're pushing for integration of mental health in the primary care setting. 2 years ago, the U.S. Preventive Task Force issued a recommendation, and that is to recommend for primary care physician, including pediatrician, to screen children the age of 12 and over for depression. How many of you have seen your primary care physician within the last 6 months? Okay. Last 12 months? Okay. Did any one of you get screened for depression? Yes, no, one. Just one. Just one. What happened to the rest of you? It's a rhetorical question, right? Even though there's this recommendation, but you know primary care physicians are not doing their job. Right? So one might say, well, why aren't they doing their job? Well, in medicine, you all know this, particularly my public health folks. If you screen people for something and they come up positive, you have to do something about it. Am I right? And so primary care physician said, well, number one, there's a shortage of mental health professionals. Number two, the system of mental health care is so complicated, I don't know what to do. Number three, you know, I only got 5 minutes with my patient. I don't want to open up a can of worms. So if I screen someone and they're positive, what am I going to do? So similar to don't ask, don't tell, what I don't know, I don't need to deal with it, right? On the average, how much time do you get to spend with your primary care physician? 5 minutes? 7 minutes? Yeah, I'm a physician. My primary care physician knows I'm a physician, and she spends 8 minutes with me. That's more than she would spend with any other patient. And I have PPO. I don't have HMO. But she doesn't have time in her schedule to spend an adequate amount of care. So therefore, you know how she screened me? I saw her 3 months ago. She didn't give me a screening tool. She said, well, you as a psychiatrist, you would tell me if you're depressed, right? And I said, first, no. Secondly, no, because you're my colleague, right? And thirdly, what are you going to do about it if I tell you I'm depressed, right? And she broke out laughing. She said, you're right. I wouldn't know what to do for you. But in all seriousness, I'm a psychiatrist. What if it's somebody who's not a psychiatrist? One of a regular patient who's depressed. So when you ask a person, you tell me if you're depressed, right? You send a signal that really I don't want to hear it if you have depression because I'm nervous. I don't know what to do about it, right? People don't tell. Right? So I think we got into this crisis of people with depression, anxiety, and what have you, and there's no way to support them and help them because there's not enough resources. So there's a model called, I have to be mindful of my time. So there's a model called a collaborative care model. For those of you interested, you could look up that. It was created by the AIM Center out of University of Washington in Seattle. What it does is employ licensed therapists, licensed social workers, licensed psychologists, and licensed marriage and family therapists in a primary care setting. So if a patient screened positive for depression and anxiety, or a patient has any kind of mental health condition, the primary care physician can pretty much hand off that person to the licensed therapist who's in the same setting. Okay? And then that person would follow the care, right? That collaborative care model would also have a psychiatrist who remotely sits somewhere to provide the support for the primary care physician to prescribe medication. So give that primary care physician the confidence to treat. So if the pediatric setting has a therapist in there, so the pediatrician could prescribe, and if he or she has any question, could pick up the phone and call the psychiatrist who is available to guide them through treatment. Okay, so that's called the collaborative care model. We actually implemented here in Orange County first. We did the bi-directional integration project. The other side of it is that there are people with mental illness that have physical health condition, but they don't go to their primary care physician, right? Because of the stigma of having a mental illness, or that they are treated differently in the primary care setting, right? Because imagine if you have schizophrenia and you're actively hearing voices, and somebody said, well, you have high blood pressure or diabetes, you need to go see your family doctor. And you walk into that waiting room and you sit, and you're having a conversation of 3 in your head, that would scare everybody else out. And that's why a lot of primary care waiting rooms, the front desk staff, are not very kind to people who actively have mental health symptoms sitting in their waiting room. Because in their point of view, you just scare the bejeebie out of a family where the young mother with their 2 young kids sitting there watching this person having a party of 1 going on, right? And so we have had clinics who we give money to hire therapists to be in there to work with people with mental illness, and they give us money back and say, no, I don't want it. I don't want those kind of people in my waiting room because they scare everybody else. Okay. Hence, the understanding now is that the people who live with chronic mental health condition like schizophrenia, bipolar disorder, or severe depression, actually their lifespan is 20 years on the average, 20 years shorter than the regular population. Not because of their mental health condition, but because of their chronic other health conditions that are not being taken care of in the primary care setting. So Riverside County and UC Riverside actually did that study. They look at all the patients who was receiving mental health care at their county mental health clinic and look at their average lifespan compared to regular folks, regular population in Riverside. And they found that people who have mental illness live 20 years shorter, even though their mental health condition was stable. And they went back and they looked at the charts and they realized that these people were having physical health conditions like diabetes, high blood pressure, heart disease. Nobody was taking care of them. So the bidirectional piece is we also now bring the primary care team into the mental health clinic to provide the primary care services in the mental health. Hence the term bidirectional integration. Okay, so either way is so important. So for my social worker, particularly for my social worker student here, you could be trained to be a social worker who work in a primary care setting, because that's very different from your typical social worker working in a mental health side of it, right? Because on the mental health side, you can learn all kind of technique, all kind of therapy that you like, and use it to provide the care for your patient, or your client. But in a primary care setting, see, that's the language differences. When you're in the mental health side of the setting, you refer to people as client. But when you're in a primary care setting, they are patients, they are not clients. Okay? So the type of therapy that you need to provide in the primary care setting is very time limited. It has to be solution focused, and basically things like cognitive behavioral therapy, psychodynamic psychotherapy, short-term psychotherapy, right? So you are expected to fix people with that very issue, and that's it. You can't be sitting on the couch and talk about chapter and stuff, because there is no time. Okay? Okay, I'm sorry. 240. There's a piece of YouTube that I want to show you. LA County Department of Mental Health, for 6 years from 2010 to 2015, did a series on recovery. They interviewed 6 people each year on people with mental illness throughout the different professions, and have them talk about recovery and what that means. And for 2011, I was one of the 6 that they interviewed because I've been living with severe depressions and post-traumatic stress disorder. So they did a piece on me. That's the reason why I strongly believe in access to mental health care. And access to mental health care means we got to do primary care integration, because there's not enough mental health professionals. Okay? So Dave thought I should share my life journey and why I particularly wanted to do this. And currently, I've not seen patients for 4 years, because my concentration now is in system change. And so let's take a look. Because of my personal experience, I'm a bit more in tune to my patients, and I have sympathy, and I actually understand what they go through. I was born in Vietnam. I was born during the war, and came to the United States in 1981 as a refugee. And my family actually spent about 13 months or so in a refugee camp in Malaysia. When we arrived, at that time there were about 50,000 refugees in that little camp. And the average death at that time was, I think, about 1 a day or so. I was sexually assaulted when I was in the camp, and that was the cause of the suicide attempt. But then think about what my family and I have gone through, and how my suicide would affect them afterward, and that's what stopped it. Everybody at that time wanted to come to America. I had an aunt on my mom's side who was already here in the United States. Of all places, Lincoln, Nebraska. We didn't have shoes, we were on sleeper. We were given jackets, though, that was good. And we came, and it was just very different. I've never seen snow before. It was very cold. We were greeted by a Catholic priest. He paid a few months' rent ahead of time for us. And we just stayed there in the house. There was a heater, but we didn't have any beds. There was nothing. My parents were very adamant that we don't want to rely on the social system. The first day that I came to the United States, that very same night, my cousin who worked in a Chinese restaurant
already asked his boss and offered me a job as a busboy. I took the job. I borrowed his clothes, I borrowed his shoes, and I went to work the same night. Arrived here in the United States at lunchtime. That evening, I went to a Chinese restaurant and worked as a busboy. And my family would together go clean apartments and houses. The whole family carry buckets, walk about 40 blocks at a time, 50 blocks at a time, just to go clean houses to earn a living. They were having a nightmare of the assault, and also nightmare of what happened after the war in Vietnam, things that I saw, and then the journey from Vietnam to the refugee camp was quite brutal as well. So I learned a way to cope with it, and the way to cope with it is if you work yourself hard to the point where your body just exhausted and fatigued, then you fall asleep at night easily without having the nightmare. The first time that truly I received treatment was when I was in medical school. That was when the depression and the PTSD got really bad. And the second suicide attempt happened when I was in medical school. And I was not making it in medical school. And one of the assistant dean was very concerned. So I got called in, and they couldn't explain why I wasn't doing well in school. I didn't realize that that was depression that I was suffering from. I wasn't willing to talk about the sexual assault because, men, we don't talk about those kind of things. We're not supposed to be sexually assaulted. And they refer me to a therapist, psychologist, but he never dealt with refugee. He didn't know. And so the recommendation was, let's do a complete battery of psychological testing. Lucky for me at that time, there was a Korean psychiatrist that immediately she knew it was PTSD and it was depression. And something about her, I guess the comfort of seeing an Asian psychiatrist made me talk about it. I was fascinated with transplant surgery. The immunology aspect of it was very interesting to me, fascinating. So that's why I went to medical school. But because of the depressions and the treatments, then the psych rotation as a medical student, I started to have an interest in psychiatry, talking to patients, finding out why they got to the point where they were, hurt, got shot, or broken arm. I wanted to know what I can do to help them. People come in, they get their body fixed, and then they went right back out to the same environment that caused them to have those trauma. And the intervention was not on time, and I found it very difficult. I knew I wanted to do psychiatry. Currently, my role for the county is a psychiatrist and also in charge of our training department. I talk about my own recovery in training. I don't hide it. I'm able to explain to them the experience, what to look for in terms of getting a treatment, what to look for in terms of seeing a therapist. We work very hard in Orange County in reducing stigma, and we strongly believe that because of cultural issues, there are barriers in treatment. And culture here doesn't mean just linguistic and ethnic, but it could be people who are homeless, people who are veterans, people who are from LGBT community, folks who historically speaking have not been able to access treatment very easily, whether it be the barriers created by the system or the barriers that are perceived by the community. In my opinion, you don't have to look like your clients to be culturally competent in providing services. You just have to have the willingness to learn about your client's culture, to understand the differences between you and your client, and to respect those differences. Cũng có rất là lâu rồi co-hosting a Vietnamese talk show called Việt View. Our show is actually bilingual. We use English and Vietnamese together, and our intention is to bring the different generation together. Most of the topic that we talk about is related to health, specifically mental health. We want to bring topic to the family's table so that when the show is done, family continue to have conversation. Different culture see mental illness very differently, especially in the Asian culture. It's still a subject that we don't talk about. in fact, even my own relatives don't know anything about depression. And when I try to help them, denial is rampant, right? And so when you deal with a client and you give them a diagnosis, you really have to spend time and talk to that client and explain it, and also get your client's perspective on what does that mean for them now that they have that diagnosis. A lot of young people have depression and are not aware of it or not seeking treatment because of shame themselves, or the parents don't want them to get treatment. But I think that depression is not treated at a younger age could continue. I mean, it's a lifelong. It is never something that you treat and it'll go away. I mean, you have to, and that's the reason why I strongly believe in psychotherapy as well. Is that you got to learn skills and technique to help you go through the life. The medication is only a part of it. The other piece is the psychosocial issues, the individual therapy, working out the issue, working out the trauma in my case, and then learn how to cope with it. Because life is always ups and downs, right? As we all know, a situation would happen, and you just need to learn the triggers, and you just need to learn when to go back for treatment. Hope is very important. On top of the list of any recovery movement or model, this word hope is significant. And hope, you mean not just the individual, but people around them, their family member, their clinician, also have to be helpful and give an individual hope. Because I think with hope, we can survive through anything. I always tell my student and clinician is that we have to be aware of ourselves. We could one moment be a hope giver, but the next moment be a hope stealer. You can never use a diagnosis and then give someone, especially someone who's young, a life sentence of nothingness. I think that's the cruelest thing anyone can ever do to a person. So I'm always very encouraging towards my clients and helping them reaching whatever goal that they set out for themselves.
Thank you. So my claim to fame is that the documentary for that year, 2011, where I was part of, actually won the Emmy Award in 2012 for Best Documentary. Hollywood not my choice. Actually, the funny thing is when they did this, they told me that, oh yeah, we only do this and we're going to air it for the patient, the client in our system in LA. And so, okay, sure. But I've not ever spoken about my experience and my depression to my relatives. So one day I got this call from my aunt who lives in Texas. And I picked up the phone and she called me and she was sobbing. I'm like, wait, what's going on? How can I help you? And she goes, I didn't know. And I said, you didn't know what? And she goes, I just saw you. And I was like, you just saw me? What do you mean? So apparently PBS picked up the series, particularly that year. And I think that's the reason why we won the Emmy Award. But it was there all over America. And of course, my relatives saw it. So they called me. And that's how I came out about my mental illness to my family, right? With all that said, I had a cousin who actually died by suicide in South Carolina. And the parents, my uncle and his wife, called me about it and told me that my cousin was suffering from this, but unfortunately it was a bit too late. We couldn't save her. She eventually died from suicide. Then my entire family talked about it. Then we finally realized that on my dad's side, one of my uncles in Vietnam many years ago attempted suicide. We didn't know, right? So it runs in the family. For those of you who work in are interested in suicide, the science of suicidology talks about the inherited piece of suicide, meaning if you look at family who had one death by a suicide and you trace it back, inevitably, a lot of those families have history of other family members also have attempted or died from suicide. So there's a genetic component to it that we don't fully understand yet. So why I'm telling you this, why am I showing you this? Is number one, Dave wanted me to show this, but it tells you that yes, there's a shortage of clinicians. Yes, we have to do something for our community, and that truly, I strongly believe the reason why we've not done very well in controlling the rate of suicide is because from a community, from a society point of view, we don't talk much more about hope and a purposeful life. And I strongly believe that if we start that conversation, that might be one of the significant ways to help people deal with stress and get into treatment. And most importantly, stop practicing a temporary solution, no, a permanent solution to a temporary problem. And that is in the last minute, when you're desperate, when you think that you're the only one, and you don't have hope, and you don't have a purpose in life, the only way out is to end your life. So we are hoping that there's a movement that will start in Orange County. We did that. There's a task force for Orange County called the Zero Suicide Task Force. We just started this January, and the task force meets every month on the second Saturday at 8:30 in the morning in a public place. That's where I was this morning because today's the second Saturday of the month. And so we met at Panera down in Aliso Viejo. We purposely meet in the public, and we have signed talk about zero suicide because we want to attract the community to come in and join the task force. By this summer, what we envision is that we will have several meetings like this happening across the county in different pocket community, and it will happen exactly at the second Saturday of the month, exactly at 8:30. So eventually we want an Orange County resident to understand that if you want to talk about suicide, if you want to do something about suicide, that's the time of the month and time of the day where you can come, and the entire community will be talking about solution to stop suicide. So for those of you who are interested in joining that, I hope you will. Please get in touch with me, and we'll send you an invitation to join the task force. Okay. With that, thank you so much for the opportunity to talk to you, and good luck in what you do. Important thing is you will never be jobless, trust me. And you will be highly sought after by the healthcare system just because your role is going to be so important in this system of care. Okay.
Coming out on Saturday and everything, you're amazing.
Oh no, thank you. I actually do have an appointment at work at 4 o'clock, so I can stick around for a little bit, then I have to run back and go back to work. So.
Did anybody have any questions or? Yeah, you have a few minutes. Anybody has questions for Dr. Chow?
Yes.
To join the task force, what would we need? Like, how would we get in contact?
Yes. Sorry.
Yeah, there's an initiative thing.
There's an email. Oh yeah, there we go. Yeah, you need my name. Send me an email. Yes.
I know that you said your family members reached out to you and saw you now have like counselors from mental health, but was it different from your
Yeah, so fascinating. I was only able to talk to my mom about my suicide attempt, but not my dad, right? Because he had very strong, he since passed away in 2011. But I went into medicine wanting to be a surgeon. I talked a little bit about it, transplant surgery. And he was very proud. But when I switched over to psychiatry, he was very upset. He didn't understand what psychiatry was. And he said, well, you need to go see a therapist before you switch over to psychiatry. What are you crazy? So throughout my training, so before I went into psychiatry, he would brag about me to all his friends and relatives, right? And then when I switched over to psychiatry, until I graduated from my residency, he did not mention me to any of his friends. And whenever his friends said, "Oh, what happened to Clayton?" he would just change the subject and talk about it. So during my residency, I actually got two honors. One is, I did very well in the residency program, and the other piece was I was chosen to be to participate in this leadership fellowship that's given out every 2 years to 10 residents of all residents in North America, U.S. and Canada. So I was chosen, and so when I graduated, the department chair talked about that, and he sat there and on his head. It finally really got to him that, yeah, there's a life as a psychiatrist, and that I did very well. But after that, then he started to talk to his friend about how, oh, if you have any issues, call my center. But I knew it was very difficult about my trauma. So when this went out on PBS, I sat down and said, listen, there's a piece of me that I didn't tell you. And to my biggest surprise, he said, son, my friend told me to see it. And I said, well, why didn't you come talk to me about it? And he said, in time. It's hard, right? The subject of depression and the subject of suicide. It's very hard in any family kitchen, dinner table. It's very hard. Because the myth is, if you talk about suicide, you encourage people to do so. And I will tell you that that is absolutely wrong. It's not true. That if you talk about it, you give people a way out. Okay? That myth still exists, that if we talk about suicide, if we ask about suicide, people will actually do it. And I'm telling you that that is not true. Okay.